Hi there, my name's Jemmima Sellicks, and today I'm going to be giving a talk on entry techniques for laparoscopic surgery. This session aims to help you guys understand the principles of safe laparoscopic entry, understanding the anatomy of the anterior abdominal wall, and also to appreciate that there's different methods of entry technique, and we'll talk through some of those today as well. And it's also important to understand the potential complications and methods to reduce risk of complication as well. So to start off with, we'll talk about what laparoscopic surgery is. Laparoscopic surgery is a minimally invasive surgery that occurs under general anaesthetic. There are four key concepts to laparoscopy. To start with, the abdominal wall is cannulated, which allows a channel to be created between the external environment and the abdominal cavity. And this allows instruments to be put inside the cavity, but manipulated from the outside. And then carbon dioxide is pumped into the abdominal cavity, reaching a certain intra-abdominal pressure, and this allows the abdominal wall to rise so you can better visualise the viscera. After that, a laparoscope is inserted, which is a camera that allows direct visualisation of the abdominal cavity. So this clear visual is created, and the surgical procedure can be performed using laparoscopic equipment. This technique is used in many specialties, but it's most utilised in gynae, but also surgeries such as lap choles, colectomies, etc. So just to talk briefly about the anatomy of the anterior abdominal wall. So your borders are, cranially you've got your xiphoid process of the sternum and your subcostal margins of the ribs. And then caudally you've got your pubic symphysis and crest, your inguinal ligaments and the iliac crest of the ilium. Talking about the layers of the anterior abdominal wall. So the basic layers from the outside to the inside. You start with the skin, and then you go down to the superficial fascia, and then you've got the muscles and their associated fascia, and then finally you've got the parietal peritoneum. In terms of the subcutaneous layer, above the umbilicus and below the umbilicus are slightly different. So above there is a single sheet of connective tissue, and then below the umbilicus you've got fatty campus and membranous scarpus. So talking now about the muscles of the anterior abdominal wall. Laterally you have three flat muscles. These are the external oblique, the internal oblique, and the transversus abdominis. In the anterior medial aspect of the abdominal wall, each of these muscles forms a broad, flat tendon, an aponeurosis, which covers the rectus muscle. The three aponeurosis become entwined in the midline, and they form what's called the linea alba. In the midline, you've got two vertical muscles. So these are the rectus abdominis, which is a long paired muscle either side of the midline, split by the linea alba, and also the pyramidalis. This is absent in 20% of people, and it's a small triangular muscle. So talking now about the rectus sheath. The rectus sheath is formed by the aponeurosis of the three flat muscles that I've just mentioned, and this encloses the rectus abdominis and the pyramidalis. Most of the time it has an anterior and a posterior layer. So the anterior layer is formed of the external oblique and also half of the internal oblique, and the posterior is half of the internal oblique and the transversalis abdominis. Below the arcuate line it only has an anterior covering, so it doesn't have the posterior, and the rectus is touching the transversalis fascia. So putting this into practice, this slide shows the layers of the anterior abdominal wall that you can see via the visiport. So starting off with the skin incision, which is the first layer, it then breaks through to subcutaneous fat, the white anterior rectus sheath, then you can see the rectus muscle, and so on and so forth, until you get to the peritoneal cavity. In practice, there are three main entry techniques, and we'll go through these briefly. So to start off with, there's a closed technique. This is where the abdominal cavity is inflated with carbon dioxide before the introduction of the primary trocar and the cannula. There's also an open technique, which is where a small incision is used to enter the abdominal cavity under direct vision. And then finally, there's the direct trocar entry. So talking more specifically now about the Veress needle entry. So the Veress is a needle with a sharp cannula tip and a spring-loaded stylet, and this allows for protection of the viscera and a reduced risk of perforation of the viscera when you insert the needle. This is used for the closed classic entry technique. So first of all, a skin incision is made, and then the verus is blindly inserted into the abdomen, and you get 2 audible clicks being heard as you progress through the muscle fascia and then into the parietal peritoneum. After this point, you connect the insufflator and inject carbon dioxide into the peritoneal cavity. You'd expect the pressure to be less than 8 millimetres of mercury. After this point, you then insert the primary trocar. So the initial inflation goes up to 20, and this should help with the trocar insertion. This is because it creates tension in the abdominal cavity, so it's easier to perforate. It's often used in gynae theatres. So in terms of the site of insertion of this verus needle, to start off with infraumbilical. This is the deepest pit of the umbilicus and is also the thinnest point, independent of BMI, as it's absent of muscle and fat. The other point that can be used is the Palmer's point, which is the left upper quadrant insertion site, and it's 3 centimetres below the left subcostal border in the midclavicular line. Prior to this, you must empty the stomach by nasogastric suction before entry, and this is indicated in previous laparotomy or a patient that's known to have peritoneal adhesions, or a patient who's very obese or very thin. So as we mentioned, this verus needle procedure is done blindly, so safety tests can be performed to basically ensure that the viscera and the vessels haven't been perforated. So to discuss these tests briefly, to start off with, there's the manometer test. This is where you connect gas tubing to the verus needle and lift up the abdominal wall, and that should result in a negative pressure. Secondly, the aspiration test. This is when you can attach a saline-filled syringe to the verus needle and you try and aspirate material. If there's nothing, that's okay. If there's bowel contents or urine, you must remove the needle. And if there's blood, leave the needle in and prepare for explorative laparotomy, as you must presume that there's been a vascular injury on insertion. Another test is the hissing sound test. So you turn the valve off once the needle is inserted, and then you lift the abdomen, open the valve, and listen for a hissing sound. Finally, a hanging drop test can be done. This is where you place a saline drop at the open end of the verus needle. You elevate the abdominal wall, and then water should disappear down the shaft, and the abdominal wall will suck the saline into the abdomen. If that occurs, then this is the correct placement. Finally, insufflation confirmation should occur. This is where you use the insufflator to measure the intra-abdominal pressure at the tip of the verus needle, and the pressure should be low if it's in the peritoneum. So the next technique to talk about is the open technique. In this technique, a small incision is made and dissected down to the peritoneum. 2 sutures either side are placed, and then a Hasson trocar is inserted through deep incision. The sutures are pulled tightly and attached onto the trocar to create the airtight seal. After this point, the insufflator inserts carbon dioxide through a port in the trocar. So the next technique to discuss is the direct trocar insertion. This is much less commonly used, but it is the quickest method and reduces the number of blind steps that need to occur by inserting the trocar before creating a pneumoperitoneum. So skin and subcutaneous tissue is sutured on either side of a small incision made at the base of the umbilicus. These are pulled up, which elevates the anterior abdominal wall. A bladed trocar is then inserted, and a single audible puncture sound signifies its breach the peritoneum. After that point, insufflation then occurs through the trocar. Different port sites are used for different functions. To start with, a primary trocar port. This is often periumbilical, where the laparoscope is inserted, and it's often a 10mm port. You also have secondary ports, and their placement depends on the type of surgery. These are used as laparoscopic instruments are inserted into these. For example, holders, sutures, crop graspers, and energy sources such as the harmonic. These are more likely to be 5mm ports. So talking now more specifically about the secondary port insertion. A trocar is an instrument used to create these port sites. And this is what we can see in the image here, and it consists of an obturator, which can be either bladed or non-bladed, and also a cannula, which after insertion is left transabdominally and creates a channel of access to the abdominal cavity. So in terms of inserting these, it starts off with a small incision made at the preferred site of insertion, and then with a twisting motion, the trocar is inserted through the abdominal wall incision. The obturator is removed and the cannula is left, which allows this channel to be created. And then after that, you can allow laparoscopic instruments to be inserted through, like we mentioned before. It's also important to be aware of potential complications of laparoscopic entry. So just to talk briefly, complications include vascular injury, visceral injury such as injury to bowel or the ureters, carbon dioxide gas embolism, and also pressure-related complications. So for this reason, it's also good to be aware of methods to reduce potential complications. So in patients who have had previous abdominal surgery, this is a risk factor for adhesions to occur. So in this circumstance, alternative entry techniques can be used, for example the Hassan open entry technique or the closed entry technique with the Palmer's point entry. In a very thin patient, the abdominal aorta can be less than 2.5 centimetres deep to the skin, so this is a really major risk of potential vascular injury. So to try and counteract this risk, alternative entry techniques can be used as well. So we can use the closed entry technique with the Palmer's point entry and also the Hassan open entry procedure. Finally, obesity is a risk factor. This is because there is a thick anterior abdominal wall and this is really difficult on entry, and preperitoneal insufflation is very common. So alternative entry techniques are used here. So you can use a Verus needle insertion at 90 degrees, and you can also use the Hassan open entry technique. Thank you very much for listening to this talk. I hope that made some sense, but if you have any questions, please don't hesitate to ask.